Hi, everyone. Good morning and good evening, wherever you are. Welcome to today's online event. This is Jill from USC. The USC graduate program events are a series of webinars devoting to spread ideas. Cutting-edge knowledge and insights from different industries and areas will be presented here by world-renowned speakers of USC. Today's topic is healthcare reform and innovation, pharmaceutical market implications in China and United States from the USC Mann School of Pharmacy and Pharmaceutical Sciences. Today, we invited two guest speakers, Ken Wong, Director of Division of Healthcare and Biopharmaceutical Business, Associate Professor of Department of Pharmaceutical and Health Economics. Welcome.
Thank you.
And Michelle Tong, who's a Program Administrator. Welcome. So please note that there will be a Q&A session at the end, so feel free to leave your questions down below in the chat box here at Zoom or on other platforms. We'll try to go over as many as we can, and please note this webinar will be recorded for future use. Please mute yourself during the presentation for a good quality event. So let's start it. Please welcome Ken.
Thank you very much, Yang. It is an honor to be here today with this group. I'm very excited to talk about the topic that I'm going to speak of, which is the healthcare reform and innovation, pharmaceutical market implications in China and the United States. It's a very dynamic time in the market around the world, not just in China and the United States. And so it's a very timely topic and a topic that is going to be with us for the coming years and decades. For those who have chosen a career in healthcare or in the biopharmaceutical industry, there's no more exciting time to be in it than today and in the near future. So if you have thoughts about joining this sector or are already in the sector, kudos to you because it's going to be quite a ride and quite an experience in the coming years. So let's talk about the topic. Well, before I do the topic, let me introduce myself again. My name is Ken Wong, and I'm the Director of the Division of Healthcare and Biopharmaceutical Business at the USC School of Pharmacy and Pharmaceutical Sciences. I'm also an associate professor at the Pharmaceutical and Health Economics Department. I spent a number of years in the pharmaceutical industry at Novartis Pharmaceuticals, primarily in the area of health economics and outcomes research, and in managed healthcare insurance. That's what we call our insurance in the United States. Prior to pharmaceutical industry, I was in the insurance industry at a number of large health plans and physician groups. And I also was an accreditation surveyor for the Joint Commission, which is an organization in the US that evaluates pharmaceutical services and quality of care standards. And then prior to that, I was a professor at another college. So what am I going to be talking about today? So today, I'm going to be talking about healthcare reform and pharmaceutical market implications in China and the US. And I'm going to hit on these 6 topics. I'm not going to be speaking on each of these topics, but they're all going to be interwoven into the lecture. We have about 50 to 60 minutes for the lecture. So the discussion will be around these different areas, and we'll pick up on different topics as we go along. But primarily, I'm going to talk a bit about healthcare reform in China and the US, talk about increasing per capita spend on healthcare, the aging population, and chronic disease. What are we seeing? Policy support for biomedical innovation, insurance coverage of expensive new innovative drugs, an issue that we are dealing with globally. And then the aspect of negotiating for lower drug prices. And this sort of connects to the prior box where we talk about expensive new innovative drugs. It's incredible what is being produced and being approved for use with patients. We have drugs that are now curing diseases where there was no cure before, or we're seeing people lives prolonged for significant years that we have never seen before. However, with that innovation comes a price and sometimes an expensive price tag. How do we ensure access? How do we ensure availability to these innovative drugs at prices that different countries and different insurance groups can afford so that they can make them available to patients? It's a concern in the United States as well as other countries. And part of that is with negotiating lower drug prices. So today I'm going to talk about the US health system and the China health system. And it just happens that I'll be talking about both. One thing I want to make note is that I'm not comparing the two systems, because as you can imagine, there are a lot of macro and environmental factors, differences between these two countries in terms of historical, in terms of market and economic dynamics, and just the size of the countries. So what works in one country may not necessarily work in the other country. So when we talk about different characteristics about the United States, be cautious in making a determination that might fit in the China system and vice versa, because these are two totally different systems, two totally different countries, and two very different environments. We'll be talking about each one individually, but not in a comparative nature. So when we start talking about health policy, and we talk about healthcare reform, we talk about how we can improve or change the systems for the better for patients. And there's different considerations in healthcare reform. Three aspects are right here. One is access to treatments. The second one is the quality of treatments. And the third are the cost of treatments. One thing to realize, and for those who are active in health policy and healthcare reform, improving healthcare systems is very difficult. One of the reasons is because there's a lot of trade-offs that must take place. So for example, if you want to improve access or have availability of all innovative drugs and treatments in your country or health system, it's going to cost. And some of those costs are likely going to be prohibitive. You can try to lower the cost of all treatments or lower the cost of all care, but if you do that, you may reduce the quality that is produced, or you may decrease the access to key treatments for people. So essentially, there's this triangle, or what we call the iron triangle, in that if you try to reform healthcare in one particular aspect, there's going to be a trade-off, perhaps in one of the other factors or in both of those factors. And that's what makes healthcare reform so difficult, and also so difficult to gain agreement upon by different stakeholders and key decision makers, because there are trade-offs that always need to be made when you make healthcare reform decisions. And what are those trade-offs? What are the best trade-offs and what are the most appropriate trade-offs are obviously specific to the particular situation, but there are indeed going to be trade-offs that are going to be made. This is a quote that you are probably more familiar with than I am, and it's a a quote by Deng Xiaoping, where he talks about crossing the river by feeling the stones. And I think of this quote when I think about actually the Chinese healthcare system, because there's a lot of pilots and a lot of experimentation with different policy decisions, provisions of care before a full-fledging program or system is put forth. And so when I go through the healthcare system timeline, you'll see what I mean. But before I talk about the China system briefly, I'll talk about the US system, because that's probably a system maybe you're not as familiar with. And as I click off some of these aspects of the US health system, you may think that it's a little odd. And a lot of it is because of our historical perspective and our history and how healthcare has risen to the forefront in this country. So in about 1940, 1945, we had a rise of employer health insurance. As a matter of fact, to this day, employers cover their employees' insurance to the point where almost half of all patients in the United States are covered by their employers. Now, this happened in 1945. It was actually during World War II. During World War II, there was a shortage of workers, and employers, in order to compete for workers, they started giving them raises and increasing their salaries. And it was leading to some very dramatic inflation, economic inflation in the United States. So the government actually prevented and passed legislation which prevented companies from raising salaries. So what did the companies do? They circumvented that system, and they told workers that they would provide them employer insurance or health insurance to cover themselves, their individual selves, and their family. It was a benefit. And from there, that system took off, and as I mentioned, 50% or more of all US citizens are covered by their employers. And then in the 60s, we have systems, health insurance that covered subpopulations. You'll find that the United States is a myriad of health insurance, and it's a myriad of health insurance for special populations. So in the 1960s, the government decided to cover insurance for the elderly, individuals 65 years and older. They also opted to cover people working poor or unemployed with insurance. We call that Medicaid. For the elderly, we call that Medicare. So for these two very large subpopulations, starting in the 1960s, the United States began covering these two very large populations. To this day, Medicare is about 20% of the population coverage, and Medicaid has surpassed Medicare. It surpassed it actually during COVID, and is now higher than 20%. Then as we go forward, starting in 2000, the US started covering prescription drugs. In the 1960s, it was all hospital and physicians, but in 2006, they started covering prescription drugs. And this is key. When I show you a slide on rising healthcare, a lot of that rise is because of hospital and physician care, but a lot of it is because the fact that the US is now covering prescription drugs beginning in 2006. Now, what we've seen in the US since then are different attempts to healthcare reform. In the United States, we still have about 10% of the population that is uninsured. Obamacare, after our former President Barack Obama, or the Affordable Care Act, was supposed to take care of that last 10%, but it hasn't really taken effect. A lot of it because of political considerations. lawsuits and all. So even to this day, we're still about 9 to 10% unemployed, and we're still trying to find a solution to cover that last 9 to 10%, but also to afford the rising costs in healthcare in this country. In China, during the same period, when the PRC started in 1949, a rural cooperative medical system was started. As we know, during that time, most of the population lived in the rural area. So there was this rural cooperative medical system that was started during that time. As we move forward, when market reform started in the mid to late 80s, the rural cooperative medical system was replaced with the government and labor insurance schemes. This was later determined by the government that additional insurance coverage schemes were needed. So in the early 1990s, there were different pilots and experimental schemes with employee basic medical insurance, rural insurance, basic insurance for urban residents that started occurring. And from those pilot insurance schemes, 3 very significant insurance schemes: the urban employee basic medical insurance, the new cooperative medical scheme, and urban resident basic medical insurance schemes were brought into the fold, to the point now where up to 95% plus of all Chinese have some form of public insurance and are covered by these different insurance schemes. Then as we move forward, there is the Healthy China 2030 initiative, which many of you may be familiar with, but it's essentially a plan to help promote healthy lifestyles and build a sustainable health system in order to provide health services to every citizen by 2020. This was a plan that was initiated in 2016. Pretty much almost got everyone there. And then the next part of the Healthy China plan was to reach the main health indicators of high-income countries by 2030. These health indicators are developed by the World Health Organization. There's a number of health indicators that range from life expectancy, birth, infant mortality, life expectancy. The goal of the Healthy China 2030 plan is to get China to those levels that are seen at high income countries by 2030. And if you've seen the measures over the last 7 years, there has been significant improvements to all those different indicators in China in actually achieving those metrics by 2030. So that I think there's a lot of optimism around that. Another thing around the Healthy China 2030 plan is to increase the total size of healthcare industry. And that's a part just to keep in mind as we talk about insurance coverage in China, but also the investment in the biomedical industry in China, how that's contributing to the growth and the size of the healthcare industry in China. So we talked about how health insurance, the health coverage in both the United States and China has increased over the past decades, or really over the last half century in both countries. One thing to take a look at when we look at different aspects of policy and healthcare reform is the dilemma, or what we call the quadrilemma of healthcare. And it's something to keep in mind, and it sort of speaks to the issues that we have with respect to the high total cost of healthcare we have in particular in the United States. So if you look at health insurance, when you start prior to health insurance or patients without health insurance, many of them would pay out of pocket. There's not many people, and if you look at across the spectrum of what people can afford, people have their salaries and pay for a lot of different key basic necessities, healthcare being one of them. But now with the introduction of health insurance in the United States in the 1950s and as well as in China, now there is a insurance body or a government that is providing insurance to pay for basic services, for hospital, for office visits, for medications, where a patient, they are paying for health insurance, but they're likely paying a monthly fee or premium, what we call it. Or they may have a share of cost where they pay a certain percentage or a certain dollar of the healthcare. They're not paying for all the healthcare. The insurance is paying for it based upon a pooling of premiums paid by the citizens. So what happens when you have health insurance? Well, now that you have an entity that pays for healthcare, there's now an incentive for technology and research and development to occur, right? So now you have monies that are available for healthcare. Now there's an incentive for companies, for individuals to innovate, to develop products that can be sold on the market or be made available for sale or for payment by health insurance. So you have these new drugs, you have new imaging machines, you have state-of-the-art equipment at hospitals as a result of this R&D. What does that result in? Well, hopefully, and in most cases, it results in higher quality of care. Now you have patients who in the past, if they had something happen to them, maybe they died, or perhaps they were indigent or crippled for the rest of their lives. Now with these new medical treatments, they have treatments, they live longer, they recover from treatments, they're in the hospital for less days, and they're at home with their spouses and their families. But with that comes a higher cost of care. You have these new medical treatments, you have these new technologies, it's leading to higher quality, but it also leads to a higher cost of care. Prices are higher for these new innovations. Innovation costs money. So you have this higher quality, you have patients who see this higher quality and this treatment, and they have demands for it. Patients want higher quality of care because they know what's available to them. So what does that lead to? It leads to a higher demand for health insurance, right? So health insurance in the United States has increased tenfold over the last 3 decades. And that is because of higher demand for utilization, and also because of higher prices because of newer innovations. So this is the dilemma of healthcare. Healthcare is fantastic. Innovation is fantastic. It leads to people living longer and living better lives, but it costs money. And the best way to achieve payment for these innovative treatments is through health insurance, through the pooling of funds from the population. That's how it gets paid for, but this is why you see this dilemma in healthcare. So you look at the United States, you look at in the 1960s when Medicare, Medicaid came into play. Again, that's for the elderly and for the poor. There was no insurance for them before. The only insurance coverage was really for employer-based insurance. Because you can see, once Medicare and Medicaid came about, it contributed to the rise in healthcare expenditures. Now you have people who get sick and have a means of paying for it through their insurance. You can see the rise in healthcare expenditures has been dramatic over the last four decades in the US. A lot of it is because of these new innovations that are available. A lot of it is because there's insurance to pay for it, which has led to that innovation, but also because of that insurance, there's higher utilization by the population in the US. And of course, we see price increases across the board as well. You see the same thing in China. The history of the social insurance schemes in China are only go back to the 1990s. But as you can see, the healthcare expenditures of urban households in China have increased pretty significantly over the last 30 years, and will only continue to rise, even if the Chinese population flattens and doesn't increase, or maybe even stays the same, or decreases a little bit. You're going to see a rise in healthcare expenditures because of the likely increase in coverage through the social insurance schemes, and the availability of these just really incredible healthcare and pharmaceutical innovations that we're seeing now, and we're going to be seeing in the coming decades. So the question is, how do you pay for it, right? How do you not just pay for it, but how do you make sure that what you pay for is cost effective and is medically necessary? And these are questions that need to be answered, and infrastructure needs to be put in place to make those evaluations. Now, in the United States, we do an okay job with it. You might be surprised by that because our expenditures are so high, but we have a very fragmented system in the United States, which prevents us from having a unified approach to managing our costs and quality. In China, with a single payer system through the insurance schemes, actually China has a better capability, as you'll see, in actually dealing with this issue. It's still a big challenge, but they actually have a better means of doing it in terms of infrastructure and systems, and evaluating medical necessity and cost effectiveness. That's an area that's still in development, but certainly is catching a lot of attention in China. So we look at, we talked about healthcare, we talked about the insurance, we talked about coverage of different populations. One thing to keep to really take a look at, and this probably is not surprising to most people here, is just the changing population, not just in China, but just around all middle to high income countries. We're seeing an aging population across the board. I think what's surprising in China is that it's happened so quickly. If you look at different reports, the population in China actually has changed dramatically over 20 years, faster than some projections. So if you look at 1970, these are tornado graphs. And what you see is on the y-axis, you have the age from 0 to 4 and upwards to 90 year plus. So you see in the 1970s, there are a lot of young people, right? And you didn't have as many older people in proportion to the younger people. And you see that for into the 80s and 90s. In terms of insurance, or in terms of of workers. Certainly having people of younger age and having a higher proportion of people of younger age in the workforce, that calls for a situation where you have a large and strong workforce that is supporting people who are retired or people who are no longer working, right? So this is the situation that you see actually in many countries in different phases of their history. You fast forward to 2020, you see an aging population where you now see almost 10% of all Chinese are over 65. You didn't see that in 1970, right? So what does that mean? That means you have a higher proportion of people, elderly, who are not working compared to the active working workforce, okay? And that causes a strain in funding, at least what we're talking about here, health insurance and these different health insurance schemes. We're seeing the same thing in the United States because we're a couple of decades ahead of you in terms of our aging population. If you were to pick out the United States, we're probably around between 2030, 2040. Our aging population forms ahead, as we call it. So, many of you know about Japan. Japan is known for having a very old population, right? They have a big head, like mine. They have a big head in that they have a very old population. But if you look at China in 2050, that tornado graph there looks somewhat similar to what we see in Japan today, where almost 28% of the population is going to be over 65. So a lot of very important policy decisions in healthcare are going to be taking place to address this issue. And as I mentioned, every country is going through this. We're going through this right now. Germany, UK, and each one of these countries I just mentioned, they have very different health systems. We are fragmented, a lot of fragmented insurance. Germany is a private, but multiple health plans. The UK is single payer, China's single payer, but we're all dealing with the same policy issues. And it just goes to show you, even you look at different health systems and how they provide care, there's not a perfect system out there. And which is one bad thing. But the good thing about it is that there's an opportunity for the world and different countries to work together to help solve these problems. So you look at China, because of the aging population, we're seeing there, and again, this is what we see in the United States over the last 20 years, because you have people living longer, people are getting old people disease, right? Elderly disease, people are living longer. So you're seeing cancers, you're seeing cardiovascular disease, you're seeing long-term effect on lungs where you have respiratory disease. But it's not just because people are living longer, because there's more financial wealth and there's more financial wealth in China. There comes with that a change in lifestyle. There's more people who live in the cities. So there's less exercise. People who typically work in busy offices, they have less time to cook nutritious meals. So you see dietary changes. You see more sugars. And then, of course, there's environmental issues that all countries deal with. But as a result of that, you see on this graph, there's an increase in the rank of these different diseases that are found in people who are older. And you see diseases that are losing in rank and not happening as often relative to these other diseases, because healthcare has improved in some aspects, but mostly because these chronic diseases are increasing in prevalence and incidence in the country. As the example, diabetes is a huge problem in the United States. About 22% of all Americans have diabetes. I won't even talk about the percentage who are diagnosed with obesity, which is even higher than that. But if you look at the United States adults, it's 13%, but overall it's 20%. In China, there's 11% of Chinese who have diabetes, and that's increasing because of age, change in diet, change in exercise. So it's estimated that about 150 million Chinese will have diabetes in the next couple of decades. Look at the expenditures in diabetes. Currently, in the United States, we spend over 300 billion in expenditures on diabetes. In China, it's 109 billion. So with this increase in chronic diseases, increase in the diabetic population, innovative new drugs, incredible new drugs that are coming out that are solving some of these problems with diabetes and lowering blood sugar. You can expect to see the expenditures in diabetes care in China to escalate quite dramatically in the coming years. So we look at the global health expenditure distribution. This goes back to my initial comment. For those who have decided to go into the biopharmaceutical industry or healthcare industry, I look at healthcare as being what we call Silicon Valley, but the computer tech industry in the next coming decades. There is just going to be such investment in healthcare, in the biopharmaceutical industry, and so many innovations that are going to be occurring. So for those who are deciding, this is just a great sector to be in, either it be in the United States or in China. If you look at the forecasted expenditures in healthcare across the globe in these different countries, you see these different countries like Australia, Canada, UK, France, they expect it to be flat. A lot of that is because the populations are actually shrinking in some of these countries, but also there's some cost containment measures that are also taking place in there, for better or for worse, we'll have to see. But you can see the most dramatic increase and actually the most dramatic decrease is in China. You're going to see, we're going to see a dramatic increase in healthcare expenditure in China over the coming decade. And again, it's because of the increase in ability to pay through insurance, and also the increase of innovation that is going to that we're seeing in the country as well. The United States, it's sort of misleading that you're going to see a decrease. A lot of that is going to be because there's an increase in China. It's proportional, right? So proportionally, we're going to have a lower share of the global healthcare distribution because the growth is going to happen in China. There are definitely cost containment measures that are happening in the US that may bring it down a bit. But if you look at our healthcare expenditures over the coming decade, it's definitely on an upward trajectory as well. So let's move on to pharmaceutical industry innovation. See, Jill Yang, I said 1 hour and you see it's not happening. So we look at the product life cycle and the pharmaceutical product of drugs. So on the left side is what you typically see in the United States. So for those who are not familiar with pharmaceutical development, typically when you develop a drug will have an increase in utilization until it hits a peak sale. That means for a successful drug will have an uptake because doctors are writing for it, patients are taking it, and you have this increase until it hits a peak sale. What you see is a decrease in time And when that happens, when does that happen? It happens when a drug goes generic. A generic means that a drug loses its patent and other companies can make a copy of it, okay? Typically when that happens, and as you can imagine, the sales of the branded drug goes down, and typically a very rapid decline. Up until recently, in China, what you saw was a sort of a different market life cycle. This is a little bit exaggerated, but what you saw in China is a slow uptake of drugs, because in China they have a national reimbursement drug list, what we call formulary or drug list. It's a list of drugs that would be covered by the social insurance schemes. Once it's covered by the social insurance schemes, you have a dramatic uptake in its use. Now, when these drugs lose patent, what we were not seeing, this is before, what we were not seeing was a dramatic decrease in these drug sales. Matter of fact, we saw sort of a flat to a slight decrease due to the generic competition. And that's because many of these drugs were continued to be used by people in China. In the pharmaceutical industry, we call that department the mature brand drug department, where essentially we have a department that sells drugs that are off patent, and but there's a market for it. And in China, there continued to be a market for it, and it's a lot of various reasons as to why that occurred. And we don't have enough time to talk about it today, but a lot of it would have to do with manufacturing. A lot of it had to do with patient preference for branded name drugs versus a generic drug, among a couple of things. But we're seeing a change now. And part of that is because of policy changes that we're seeing in the country. Now, there have been different policy changes, regulatory changes in the pharmaceutical regulatory review system, where there are now expedited drug reviews for innovative drug treatments, which show high promise to cure disease or to treat a disease. Now these drugs, instead of having a very extended review time, which keeps them out of the hands of patients, now we're seeing these drugs that are being approved more faster and going into the market a lot sooner. And we're seeing overall drug approval time compressing in China, and is quickly approaching what we're seeing in the United States and in the EU. If you look at the number of what else changes we're seeing, is you look at the number of drug approvals in China over the last decade. Not only are you seeing increase in innovative drug treatments, many of these are, but you're also seeing an increase in domestic drugs that are actually being produced in the country versus those countries that are being brought in by multinational foreign countries. So you can see in 2021, pretty dramatic increase where you had 32 drugs from multinational companies being approved in China versus 38. Pretty dramatic increase if you look at the graph to the left, where the numbers were a lot smaller, but most dramatically is with domestic drug approvals. Now, not only that is, as I mentioned, is the time needed for approval of new drugs in China, that's decreased. So if you look at 2011 to 2013, the median number of months for an NDA or a new drug approval was about 20 months. Fast forward 2017 to 2021, now it's about 16 to 18 months. So improvements there. A lot of that has to do with what I mentioned with respect to the expedited review and also some changes in the regulatory process as well. In terms of pricing, as I mentioned to you, the mature drugs, and you see that you see how when a drug went generic, you didn't see a dramatic drop in generic use. Well, that's changed, and a lot of that is because of volume-based procurement process that started, I believe it was in 2016 or 2015, where essentially now the country is flexing their muscles, and they're really leveraging their NRDL list, is essentially going to drug manufacturers and saying, hey, we have this national drug list. Only drugs that are on this drug list will be covered and will be paid for. And not only that, for those drugs that are generic, we're only going to make up to three drugs available. And it's going to be a competitive bid process. So it started off with the 4-7 cities program, where essentially the government went to the different drug manufacturers, both domestic generic makers and these multinational brand drugs companies, and they essentially said, bid for a place on our national drug list. And as a result of that, and there are multiple bid processes in the process, you had companies that were bidding upwards to 50 to 70% lower prices for their generic drugs to end up on the list. And you see this dramatic discounting happening to this date. Essentially, the value-based procurement program gives drug companies an opportunity to have their drugs available on NRDL, to be available in these public hospitals, but they have to exchange it for a large discount. It didn't happen before. So now you're seeing these very steep discounts because of the bidding process and the limited number of drugs per drug group that they're making available. Why does a company want to be on this drug list at a 50 to 98% discount? Because essentially they would lose their place in the market with the public insurance scheme. Sure, there's private insurance, but it's a small part of the public insurance scheme in China. So you're seeing some significant discounting that's occurring. And that's making a big difference in terms of generic uptake in the country, which is fantastic. If you think about a country that used to spend a large proportion of their money on drugs that could have been purchased generic, that same amount of money can now be used toward paying for more effective or innovative treatments that we're seeing in the country. So a significant shift in funding is seen as a result of that, and it's a very good thing. It's very and excellent planning as well. I'm going to skip this part because we're getting towards the end. Essentially, what we're seeing between policy and the biopharmaceutical industry in the United States and China, we actually share a lot of common challenges, but in different ways. In the United States, we're trying to continue to balance attempts to lower drug prices without decreasing biopharmaceutical innovation. In the United States, we pay the highest prices. In a lot of ways, we subsidize a lot of the R&D that's occurring out there. And as a result of that, lowering drug prices in the United States may have a significant impact on pharmaceutical innovation. And we're dealing with some new legislation and regulations that are impacting that. We still have a 10% uninsured rate in the United States. That's an area that we still need to be innovative with what we're trying to do there. And we're also trying to control costs. In China, we're continuing to see an increased per capita spending on health insurance. That health insurance, some of that health insurance is being put towards the coverage of innovative drugs, as well as investment in the industry. Price negotiations are effective, and as I mentioned, has really helped shift the financial equation in terms of pharmaceuticals in the country. And there continues to be significant investment in China in R&D in the biopharmaceutical ecosystem, which is helping to grow the domestic biopharmaceutical market. So I'll just leave on this part with respect to those who are looking for careers in the biopharmaceutical medical technology industry. This is from a McKinsey report, and it's their evaluation of Chinese biotech companies and the industry. What these companies are looking for are people who are skilled, people who have knowledge, people who are innovative, who are enthusiastic, who are trained in the biopharmaceutical industry in terms of product launches, data analytics, pricing and reimbursement, medical information, medical affairs, regulatory, and research and development. These are all areas that are keen skill sets that some of you may be seeking to develop where you are. And these are definitely skill sets that are being highly sought after by different companies, whether they be in the product industries or in the insurance industries. So a bright future. So let me spend the last few minutes talking about the program that Michelle and I are a part of. At USC, the University of Southern California, Mann School of Pharmacy, School of Pharmacy and Pharmaceutical Sciences. We have two master's programs, Masters of Science in Biopharmaceutical Marketing and a Masters of Science in Healthcare Decision Analysis. In these programs, we actually teach and train our graduates in all those areas that I just mentioned. We train students in strategy and marketing in terms of pricing strategies, market access, reimbursement, payment strategies, product commercialization. We teach students on quantitative data and decision analytic skills in terms of areas of health economics and outcomes research, decision modeling, literature evaluation, market research, and then health policy. With healthcare reform, a lot of that is happening around the world in China and the United States. There's really, you cannot talk about different markets, and you can't really make any business decisions without understanding health policy, because that is where the rules and parameters are built upon, where you make your business decisions on. So we look at these three key areas as being the foundations for our two programs. In our program, we have a wonderful faculty, but we really take advantage of industry leaders. We have real-world experts from pharmaceutical companies, from different trade groups who are actively working in these areas day to day. And we bring these speakers to our program, and they make a big part of our program. So on one hand, you hear from these fantastic leaders in their industries. You also get the network, and you get to meet physically, face-to-face, and emails if you wish to afterwards, and meet these people and learn from them to help support and grow your career in the future. Graduates from our program go into pharmaceutical and medical technology companies. They go into health insurance. Many of them go into healthcare consulting like LEK, IQVIA, and a lot of them actually go into healthcare finance as well. Our graduates are at some of these companies and many more. But as you can see, a lot more pharma companies, med device companies, insurance companies, and a lot of consulting and finance companies. So with that, I will leave it there. And I'm not sure if there's opportunities for questions, but I'm open to take any questions.
Yeah, sure. Thank you so much for very detailed information introduction and anything like that. It's mind-blowing to me. It's like a mini window to like a new world or the pharmaceutical world. So time-worthy. And we received a lot of questions from other platforms for now, but just a kind reminder, we've received over like 6,000 viewers from all of our platforms right now, and it's like a very good score for today's event. So lots of people are focusing on this industry and are interested in the issues. So the first question I would like to ask is from an audience saying, what's the difference between biopharmaceutical marketing program and healthcare decision analysis for career path?
Okay. Yeah, that's a great question. Biopharms, so there's actually a little bit of overlap between the two in that both of the degree programs actually go, many of the graduates actually go into the pharmaceutical and med device industries. The biopharmaceutical marketing degree program is more around commercial marketing and brand management and product development, but it's really more around brand management and product marketing, which includes marketing and advertising. The healthcare decision analysis program is more analytic, is more quantitative. So we'll have courses in there with respect to data analytics. We'll have modeling courses. We'll have health economics topics. But many of those graduates will also go into pharmaceutical marketing and brand management, but they'll have more of a technical background as opposed to more of a commercial marketing background. So the biggest difference is really more that the healthcare decision analysis program is more quantitative classes and skill sets, which where the training is.
I absolutely agree with that, with everything that Dr. Wong just mentioned. And I just want to add another difference between biopharmaceutical marketing and healthcare decision analysis is that healthcare decision analysis is a STEM certified program. So students, international students in particular, who pursue HCDA are qualified for a STEM OPT extension, whereas biopharmaceutical marketing is just OPT.
Got it. Thank you. And the next question, someone asks, I do not have any healthcare experience. My major is marketing. Do I have the opportunity to be considered by any program in the school?
Yes. Yeah, so absolutely. So actually our program, this is what I love about our program actually. Our program, if you look at the students in our program, they look like people's, their backgrounds look very similar to people's backgrounds at a pharmaceutical company. What do I mean by that? We have people who have biology degrees, chemistry degrees, but we also have people who have economic degrees, finance degrees, business degrees, and marketing degrees. What you want to pursue is going to be pursuant to what your interests are and what your skills are. But when you look at a pharmaceutical company, you have people with very technical backgrounds. These are going to be more the analytical people. Then you're going to have people who are more interested on the commercial side. Our program trains students in both areas. So if you have a marketing and business background and you have an interest in healthcare marketing and business, our courses will teach you that. If you're interested, if you have marketing background and you want to do more analytical, our courses are designed so that even students with just with business and marketing backgrounds with no healthcare background, they will succeed. There's going to be certainly some ramping up in terms of your healthcare knowledge, because the glossary is different, the terminology is different, and you will have to learn that. But our program is designed so that you will learn that, and there is time to be able to do that. So the take home is, yes, marketing, definitely we welcome the marketing and business students. They bring a very unique perspective to our class, just like our biology students bring a different perspective, and it brings a very diverse classroom conversation and group activities, because we have such a diverse student cohorts as a result of that.
Sounds good. Following that, someone asks, do I need any professional pre-courses or requests to study or learn themselves before applying for this program?
Actually, our new students, when we admit them, they all ask that, which is fantastic. But I would say that our program is set up so that you don't. Certainly, if you want to do reading on medical terminology, if you want to do readings on the healthcare system and healthcare policy in the very basic foundational sense, sure, pick up a book, read some articles, general articles. Don't go too deep, because we certainly have students from different backgrounds who come into our program. And after the first couple of weeks, maybe a month, they're all caught up, and they're able to go along with all the other students who may have a background in that area or may not. But I wouldn't be worried about it. But if you want to, if it makes you feel better, yeah, do some foundational reading, but you don't need to do that much more than that.
Okay, clear enough. Thank you. And following that answer, is GRE required?
Actually, that's a great question. Up until about 3 years ago, we required the GRE, and we thought the GRE is the best predictor for student success in our program. And what we found is that it had no bearing and no correlation to our student success. Students who did really well with the GRE did just as well as students who did average GRE. So as a result of that, and as well as many other programs at our school and other schools in the US, many of them have actually taken out the GRE. So we don't have a GRE requirement. Our primary evaluation is the student and their schoolwork prior to coming in, their undergraduate work. And also we take into account work experience as well, but we do accept many students who are from who have just graduated as well.
Okay, got it. Thank you. And let's move back to Zoom. I see several questions popping up. So the first one, Yu Fan asks, says, hello, professor, which one is more harmful to public health? Alzheimer's disease or Parkinson's disease? Does Parkinson's disease count for the same proportion of health expenditure in China as in the US?
Yeah, that's a very great and very thoughtful question. first of all, I'm not I have not done research in Alzheimer's or Parkinson's or other neurologic diseases, so I can't really speak to the prevalence in the different countries. I mean, both are very, very devastating diseases. I would venture to say that the prevalence of diagnosed Parkinson's and definitely the prevalence of Alzheimer's disease is much higher in the United States. Diagnosed, and which means we've identified patients with those diseases. So I can pretty safely say that we have a higher diagnosed population of those two neurologic diseases in the United States. In terms of prevalence and incidence in the general population, I couldn't really tell you. I mean, there's a lot of factors that go into that, but in the United States, definitely a higher proportion of patients who are diagnosed and treated for both, and subsequently treated for those diseases in the United States are higher. And in terms of expenditures, as a result of that, this is just my educated guess. As a result of that, my guess, even though China has a bigger population, my educated guess is that our expenditures are probably higher, not just because of the availability of drugs that we have here approved for those treatments, but also because of probably the higher proportion of diagnosed disease of both those neurologic states.
Right. Okay. Thank you.
Yeah.
The next question from Haoran Tao says, "Hi, Dr. Wong. Do you think the volume-based procurement, right? Sorry, bear with me, is a sustainable approach for the perspective of health economics?" Thank you.
That's a great question. And I would answer that in two phases. So I think in the immediate phase, it definitely has a place and it's much needed. I think that it's very important and a capability for, especially if you're going to be a single payer system, to be able to leverage your heft and your discrete list of drugs that you're willing to pay for in terms of negotiating lower prices, more immediately because of the fact that there are mature brands and there are generic drugs. And I think there's still a lot of runway, I think, to lower costs in that area. So I think in that first phase, I think there's still runway. And I think there's still opportunity to lower and manage costs in that way. In the long run, is volume-based procurement going to be sustainable? That's where I think we're probably still some ways away from that. There's going to be a point where certain manufacturers, especially for branded drugs, where they're the only drug on the market, where maybe a drug manufacturer might push back, right, on a country, a single payer like China, and essentially say, we might not want to participate in your bidding process. It doesn't make market or business sense for us to do that. And all you have to do is go to Europe, to the UK and Germany, where essentially those countries and in those markets, you have some companies that after long negotiation processes for respective certain drugs in those markets, you have some companies that are pulling their drugs from the market rather than participate in that market because the negotiation and drug pricing isn't meeting their business need. So certainly, so is volume-based procurement sustainable in the short term? Definitely opportunity and runway for it. in the long term, whenever that might be, yeah, there's going to be a point in time where there's going to be some very tough negotiations, and where there is going to be perhaps pushback and leeway that's produced, and some tough negotiations that are going to have to occur between payer and manufacturer.
Thank you. Let's move on to the next question from Scott Shu. Dear Professor, what do you think of the HEMA or health economics model perspective in Chinese market when facing the VBP? A lot of terms.
Yeah. So essentially, for a drug to be approved or to be utilized in a particular market, a payer has to assess whether that drug is cost effective versus other treatment options, right? So maybe versus a competitor drug, or perhaps whether the drug is more cost effective than surgery or other medical treatments. So in order to make that evaluation, health economic modeling evaluations have to occur to make that determination. So a country like the United States, we have different health plans that make that evaluation. In China, they have a body that is making that evaluation, making a determination, well, should this drug be covered on our drug list because it's cost effective and that it's more cost effective than other particular treatments. So in the United States, we do have that evaluation that occurs, but it's very inefficient. A better model is probably the UK and Germany, France, and some of those other European countries, where they have these health technology assessment organizations that do those exact evaluations. Does this drug that we want to put on our drug list, does it belong there, and should we pay for it? As I mentioned, the United States, we're fragmented. In China, it's still beginning, right? So the technology assessment, the modeling that's occurring there is certainly occurring. It's developing, and it's developing its sophistication. In terms of its utilization in health and drug decision coverage decisions, it's being referred to, but it's not to the point with what you're seeing in the UK with NICE, where the HTA entity has to put in a positive recommendation in order for it to be covered. In the Chinese market, we're not seeing that, but it's definitely going to be needed in the far, if not the near future, because there's going to be some very difficult decisions that are going to have to be made. That's not just based upon the price of a drug. And for those who are in the pharmaceutical industry, I think Scott probably is in that industry, we know that the value of a drug is not about the drug price. The value about a drug is the value that that drug brings to the patient and to the health system in terms of making perhaps making the patient feel better, curing a disease, decreasing hospital days, making it so the patient lives longer so that they can see their grandchildren. A lot of these aspects are what we consider value, and we can attach numeric numbers to those aspects in our modeling. And that is what's more important than the price of a drug, although the price of a drug has a pretty severe component to the value of a drug. Is the higher the costs of a drug, it lowers its value somewhat incrementally. So the long story short, Yes, health economic modeling is going to be a very important aspect in China in the far, if not near future. And I believe that it will be consulted more so by decision makers in the Chinese market when determining whether a drug should be put on their NRDL. It's not there yet, but it will be.
Right, sounds good. And our last question is asking about health economics program. Is there any way to for you to share more about this program or any link or website?
Yeah, so I think Michelle just shared the link because, and actually whoever, is it John? John, if you want to email Michelle or myself, we'd be glad to talk to you about it on email or Zoom. It would take probably too long to talk about it. I would just say the healthcare decision analysis program, biopharmaceutical program are excellent. The health economics program that we have is also excellent as well. That's a sister program that we have. But I would go to that website or contact us directly, and we'd be more than glad to talk to you about it.
Yeah. And last but not least, as a little tradition, is there anything you'd like to say to our audience?
Michelle, I'll let you go first.
Oh my goodness, way to put me on the spot. How did I know you were going to do that? Well, I think what I want to say is that the fact that you are all here today tells me that you're interested in healthcare, which means you're interested in the right thing, a career in healthcare. You've made the right decision to attend today's seminar, to listen to Dr. Wong's wonderful presentation. And I hope you'll take the next step and think about a career in healthcare consulting or biopharmaceuticals or biotechnology or medical devices diagnostics. I mean, the list goes on and on. And that if you have any questions about healthcare decision analysis or biopharmaceutical marketing, please reach out to me. My email is right there, tonm@usc.edu. I would love to connect with you and tell you more about what we have to offer.
Great, thanks, Michelle. I'll end on this. I've been talking a lot about healthcare business. I've been talking a lot about the career opportunities there. I've been talking a lot about innovation. I've been talking a lot about pricing and value. And I'll actually attach a little bit to what Michelle just said about this is the right place. And I'm going to go to many of the applicants to our program. And there's someone who mentioned that she's in marketing. I think there might be someone who does economics, Horan probably. And what I found with all our applicants, and including myself, I'm a PharmD by training, is the people who decide to go into this industry, the healthcare industry and biopharmaceutical industry, they're doing it, yeah, because it's a career. But what I find from talking to a lot of young people is that they want to go into healthcare because they care. They care about people. They care about making the world a better place, to improving healthcare, improving health equity, improving access to care. You know, they'll talk about their cousin, their brother, their sister, their parents, their grandparents, the experiences that they had that changed their lives. And that's what's led them to the point where they come on to a webcast like this, and they want to learn about these different healthcare programs. Some go into treating patients. They become physicians. They become nurses. They become pharmacists. They become healthcare workers where they deal with patients directly. But then there are others who want to improve healthcare in populations. They want to improve things in the macro sense in making a healthcare system better and more efficient and accessible to people. And that's sort of what our program's about. It's about improving healthcare, improving population health by improving healthcare through making better policy decisions, improving healthcare by developing better systems and miracle drugs. And I don't use that miracle lightly. there's just been some incredible drugs that have been created over the last a number of years. But all of you are here for a reason. It's because you guys care about people, you guys care about health, and I applaud all of you for being here today. And also thank you all for joining Michelle and I for this webinar.
Until next time, bye everyone. Thank you so much.
All right. Thanks, everyone.